this morning. It's my honor to formally introduce Dr. Michelle Angeline. Dr. Angeline is a native of Charleston, West Virginia, who attended WVU for her undergraduate education, earning a bachelor's degree in exercise physiology with the Latin honors of magna cum laude in 2013. During her undergraduate years, she served as the lead scribe in our emergency department, and as many of the attendings first got to know her in this role, and it's been incredible to watch her grow professionally over the past 8 years. She attended the WVU School of Medicine, where she was elected to membership in the Gold Humanism Honor Society, and we were fortunately able to keep her home for her residency training. This summer, she'll be staying with Ruby and Uniontown practice sites. Please join me in welcoming Dr. Angeline as she gives her senior grand rounds.
All right. Hi, guys. Thanks, Kiefer. Hi to my entire family as well. My mom, dad, Nathan, and mother-in-law are listening. So those are the other random people on here. So I want to do a little experiment to start with. I can see some of you in the grid view. I'm going to read out some phrases, and I want you to raise your hand so that we can see it if one of these things has ever been said to you in the patient care setting or by friends, family. So let me call you back. The nurse just walked in. Okay. When will I see the doctor? So, what kind of nurse do you want to be? How's your significant other handle you working all the time? Who watches your kids while you're working? Are they upset with you for having children during residency? I've never had a woman doctor before. Literally, one time at UHC, somebody said, 3 different patients said this to me in one shift. It was amazing. So, my grand rounds is going to be a bit of a mashup. I entitled it SheEmergency. I'm pretty passionate about female, basically, challenges in the field of emergency medicine. But when I was trying to decide what specific topics to talk about, there's so much. So I tried to narrow it down to things that I feel I have the most experience with. So I entitled it Babies, Breakdown, and Battling Microaggressions. So some objectives for today. Discuss pregnancy and maternity leave challenges, specifically for female physicians. I want to highlight specific challenges to well-being that we may encounter during pregnancy and immediately postpartum. And then talk a little bit about how microaggressions and gender stereotypes can affect patient care, leadership style, and interprofessional relationships. So let's start with babies. Maternity leave could be a topic in and of itself, just in the United States. So I thought I'd start with an overall broad view, then we can talk specifically about in residency training programs. So I'm sure you guys have heard of AOC before. She had a tweet that was pretty popular. Puppies aren't separated from their moms until about 8 weeks. Less than that is thought as harmful as abusive. One of the most common lengths of US paid maternity leave is about 6 weeks. So yes, when we let the market decide on parental leave, the market treats people worse than dogs. So here's some 2018 data on paid maternity leave by country. Again, this is paid. So Australia has 18 weeks with 42% at an average payment rate with 7.7 full rate equivalent weeks. And then you notice the United States, we're down here at 0. So in the United States, you have 0 guaranteed paid maternity leave. What about FMLA? So naively, as many of you all know, I came into intern year super pregnant, in fact, delivered the night before intern year started. I remember sitting in intern orientation, emailing HR because somehow I had asked when our first paycheck was going to be, because I was trying to figure out how we were going to pay for diapers, daycare, and everything just coming out of medical school. And I was like, oh, we'll be fine. I'll get my first paycheck. It'll all be great. And then I get this email that says your leave is going to be unpaid. And I was like, what? I was like, I've been at West Virginia for 4 years. I've been in school. I don't understand how I'm not going to get any pay. I said, well, you don't qualify for FMLA. So in order to qualify for FMLA, you have to work for a covered employer for at least 12 months. So as a new resident coming into a residency program, being in medical school at the same institution doesn't count. FMLA was created in the 1990s by the Clinton administration. And before that, it was actually legal to get fired for requesting maternity leave. So the goal of FMLA was to try to protect parents from that discrimination. But FMLA is 12 weeks of leave, unpaid, in a 12-month period, which is better than no leave, but unpaid doesn't help basically support your family if you're the sole provider. So what does ABIM say about leave? You're required to complete 46 weeks of training at each level. Greater than 6 weeks off during a year of training requires an extension. And actually, I didn't know this until I was looking it up on ABIM's website. If a program wants to be more restrictive about leave and offer less than 6 weeks, they're allowed to, basically on their own will if they want. ABIM says you can do whatever you want as long as it's not more than 6 weeks. Less is fine though. And leave cannot be accrued from year to year. So it's all well and good. Say you qualify for FMLA. These are just the average prices of the very, very essentials for a baby. Average out-of-pocket cost for birth, even if you have insurance, is about $4,500. Crib from Walmart is $164. You gotta have a crib mattress because it can't just sleep on the wood, $49. A car seat, $160, and that's one car seat. If you have 2 cars, you get to transfer it back and forth. 1 box of diapers that'll last a couple weeks, $41. Wipes, $10. If you're on formula, that's $36. That lasts a couple weeks. And infant daycare around the Morgantown area is $205 a week. So on an unpaid resident salary, just for daycare, you're looking at about $10,000. And that's with you going to work, less than 6 weeks of maternity leave with no pay. I don't know who could do that or who could afford that, but we sure couldn't. So this was from JAMA Surgery of 2018, entitled Pregnancy and Motherhood During Surgical Training. It was a 74-question survey sent to current and former surgical trainees from 2007 to later who had 1 or more pregnancies during residency, with an N of 347. The goal was to characterize the experience of women surgeons during pregnancy throughout residency and to identify potential areas for improvement. So you can see most women had their babies 4th and 5th year. Most women had 1 baby during surgical residency. Somehow 6 women had 3 babies during surgical residency, which I consider them to be superheroes. So most agreed that they would be negatively perceived by their peers if they asked to work a lighter schedule during pregnancy. They were worried they would cause resentment. They worried that their work schedule would affect the health of their children. They agreed that there was a negative stigma being associated with being pregnant as a resident. Most took less leave, and both felt like their leave was a burden to their co-residents. Most felt it was easy to discuss their maternity leave with their program director, so that was a positive. And the majority disagreed that their length of maternity leave was sufficient. American Board of Surgery's leave policy is actually different by year, so they can take 12 weeks away during the first 3 years, 4 weeks a year, plus 2 weeks for pregnancy or medical leave. But if they have the baby in the 4th or 5th year, they can only take 8 weeks away during the last 2 years. I assume because they want them to have like a higher OR caseload. I kind of really related with this. Most agreed that they would perceive to be uncommitted or a bad resident if they went home to see their child instead of staying late for a case. Basically, and they were worried that they would be perceived as behind in terms of skills because they had less time to dedicate to work. So in summary, 59% reported that they felt a negative stigma with pregnancy in a surgical residency. 85.6 worked an unmodified schedule until delivery, which as a surgery resident sounds awful. 63.6% felt that their work schedule negatively affected the health of the mother or the baby. Almost 80% received 6 weeks or less of maternity leave. 58% stopped breastfeeding earlier than they wanted to. Only 63.4% reported access to lactation facilities. Does anybody know where our lactation facilities are? So our dedicated lactation facilities, there is one room outside the PICU that is locked. And in order to get to it, you have to go to the NICU front desk and be let in. There's only one person allowed at a time. So that room is shared by all of the nurses and all of the physicians as technically the lactation room. There's also a lactation room in the HSC, basically on the first floor, kind of near the coffee shop, which is about a 10-minute walk. Obviously, you can pump in other places like many people do, but those are our dedicated lactation facilities, which are supposed to be convenient and available to all. 85% felt uncomfortable asking their staff to stop and pump. And the part that was most discouraging to me was that 29% would caution a female medical student against a career in surgery because of how they felt pregnancy and childbearing was perceived and the challenges that they had, which is discouraging because I don't think you can change a culture if the women in that field are actively discouraging other women from going into it. I don't think there's going to be much change. All right, so the high points basically from that article. 2/3 of female surgeons felt their work adversely influenced the health of them or their baby. Half stopped breastfeeding before they wanted to. And greater than 1 in 5 would caution females not to pursue a career in surgical training. All right, but this is a little positive PR I found on Twitter. This was a surgery resident, I think she's a 4th or 5th year, who tweeted about her staff setting up for a trauma case so that she could pump. And there was a big movement on Twitter for surge parenting, and I look like a surgeon, meaning women also look like surgeons. So there is a positive movement towards, adapting to women pumping and childbearing during surgery, which was nice to see. So this was a study in the Postgrad Medical Journal of 2018. And it was entitled Childbearing and Maternity Leave in Residence and Determinants of Wellbeing Outcomes. It was from the University of Washington. They did an anonymous survey of female residents across 24 of their GME programs with an N of 214. They wanted to characterize basically what parts of maternity leave or postpartum had the most effect on well-being, and to identify factors that residents identified as reasons for delaying childbearing. The mean length of maternity leave was 8.4 weeks. So most respondents felt that family finances were the biggest reason they were going to delay. And obviously, as we talked about, if you're not getting paid, affording childcare and to clothe and feed your child is a little difficult. So here are some of the outcomes for well-being. The p-values, as you notice, are not statistically significant, but I would like to point out the negative postpartum depression screen. So in women who took less than 8 weeks of maternity leave, only 30% would screen negative. So that means 70% would screen positive on the postpartum depression screen, which we'll talk about in a little bit. That's a lot to me. And 81% who were married or partnered but were not pregnant were intentionally delaying childbearing during residency. So this was from the American Journal of Surgery in 2016. As you can tell, the surgeons have a lot of literature on this. We don't have as much, but this was resident perceptions of pregnancy during training from 2008 to 2015. A survey distributed to female resident physicians and then to female and male physicians in the subsequent years through multiple specialties at a single site institution. They both agreed that men and women both agreed that there's a negative stigma attached to being pregnant during residency, but men reported less perception of this stigma than women, obviously, I think. Most identified personal considerations were the biggest factor that influenced decision of childbearing, more than attitudes of peers and residents. And then female residents were more willing to consider pregnancy with a female program director. On that note, I'd like to give a little shout out to Erica, who's been super supportive of me during both my pregnancies. It's been greatly appreciated. This was intern year. I went into birth 3 days later. Okay, I'd like to transition into the breakdown portion. This is kind of a talk about well-being during pregnancy and postpartum, and kind of where we have to improve. So a lot of times people will mention like, oh, have a great break. Like, how was your break away? Did you get a good time? You know, was your maternity leave a good rest? You get time to bond, things like that. You do. But I found this quote to be very indicative of maternity leave. So a reminder to businesses, maternity leave is not a holiday. It's not a nice break. It's not time off. It's a heady cocktail of anticipation, expectation, arrival, and survival. It's stripping yourself back to a primal state and nakedly navigating blocked milk ducts, torn stitches, bloody sheets, broken minds, manically Googling blackout blinds. You're needed. Every second you are needed, if not in person, in mind. It's a job. Without sick days, without fair remuneration. It's the most privileged position in the world, but it takes balls, guts, often with no glory, boobs, and any other extremity you can put to work. It's the purest happiness. It's the starkest of contrast. It's hobbling to the park post-birth, riding an oxytocin high, returning home, crumpling into the fetal position, succumbing to a postnatal low. It's life in its purest, ugliest, most startlingly beautiful form, and it's raising others higher, above your hunger, above your exhaustion, above your needs. It's raising the next generation. So this was an article from Nursing for Women's Health in 2019, and it's entitled Women's Choice Regarding Breastfeeding and Its Effect on Well-Being. Is Kristen here? Is she on? I can't see her. Yes. Hey, Kristen, would you mind telling everybody what it entails to pack your pump bag for work?
Sure. So I have to make sure that I have both of my pumps and that they are charged. If they are not charged, I need to make sure that I have both of my chargers so that I can plug them in the resident library when I get there. I need to make sure that I have all of the pieces. So it depends on whether I'm pumping with my bags or my containers, but either way, both setups have multiple small pieces that if one is missing, they will not work. I need to make sure that I have a bag to put those pieces in between my pump on the way to work and my pump at work. And then I need to make sure that I have drinks and snacks for myself so that I can continue to make milk to pump. So it's no small ordeal, I guess.
Sounds easy, right? Like you can just roll out of bed and do that. There's no pre-planning, let alone if the baby's hungry before you leave for work. So for those who haven't experienced or lived with somebody who's breastfed or pumped, I thought, just kind of getting an overview of what it takes to breastfeed is a little bit eye-opening. So this study between 2009 and 2015, basically looking at all data. This wasn't specifically in residents or anything. This was just in all mothers. 1 in 5 mothers of infants did not breastfeed. And in those who did, 1 in 4 only did so for 6 months. I'm sure for a variety of reasons, because it's not easy. The perception of breastfeeding before I had children, especially in medical school, on pediatrics, they always say breast is best, breast is best. Breastfeeding's hard. It doesn't come naturally to most people. In the movies and in medical school, it seems like, babies should be born and they should just know how to breastfeed. It often doesn't happen like that. So I think it's important just as a side note, to be empathetic to moms in the emergency department, either if they're trying to breastfeed with providing them pumps from labor and delivery, or if they say they're on formula, to not be judgy, because it's hard, you know, the baby needs to be fed, whether that's formula or breast milk, honestly. As long as the baby's fed, that's what we should focus on. So women with negative early breastfeeding experiences are more likely to stop breastfeeding and more likely to have depressive symptoms after birth. In my opinion, being an intern, trying to figure out what the hell you're supposed to be doing, finding a lactation room, pumping with trying to maintain all of your duties, I'm talking off service, not in the emergency department, just even off service, trying to figure out what fridge you're supposed to put your milk in that's not gonna, you know, be thrown away, to me counts as a negative experience. And I think we have a lot of room for improvement in regards to access to lactation facilities and supportive breastfeeding in the field of medicine. And then I like this quote from that article. "We must not forget that a physically and psychologically healthy mother is likely better to care for an infant than one suffering from depressive symptoms or exhaustion." All right, so leading into postpartum depression. This is data from Morbidity and Mortality Weekly, trends in 27 states from 2004, 2008, and 2012. So in a self-reported survey, 9.8% of women experienced postpartum depressive symptoms. I personally think it's much higher than that, as it's self-reported. I don't know what depressed woman with an infant is going to take time to fill out a survey to the CDC to tell them that they're depressed. Not very many. Prevalence is higher among new mothers who obviously were younger, of American Indian, Alaskan Native, or Asian Pacific Islander descent, less than 12 years of education, unmarried, postpartum smokers, 3 or more stressful life events in the year before birth. I think residency is pretty stressful. I don't know if you would count it more than 3, but I think it's a pretty stressful experience. Those who gave birth to term, low birth weight infants, or had infants requiring NICU admissions at birth. So this is the Edinburgh Postnatal Depression Scale. So if we just take a look at this, I've been able to laugh and see the funny side of things. I've looked forward with enjoyment to things. I have blamed myself unnecessarily when things went wrong. I've been anxious or worried for no good reason. I felt scared or panicky. Things have been getting on top of me. I've been so unhappy that I've had difficulty sleeping. I have felt sad or miserable. I've been so unhappy that I have been crying. The thought of myself has occurred to me. I challenge any intern to take this survey, and I guarantee you they would at least get a couple points. So especially women who have babies during residency, it's easy for us to be terrible patients. So you know what your OB wants to hear, and you know what is going to score low on this. So if you don't want to talk about your postpartum depression, it's very easy to avoid it. And in my experience, if you're a healthcare provider, other healthcare providers feel uncomfortable approaching this topic with you. So I had postpartum depression after my first son, Luca. Both after Luca and Miles, my youngest son, I was never asked to fill out this survey. I don't know if it was because I was a resident. I don't know if it was because I was good at lying. I don't know if it's because, I'm not really sure of the reason. But I challenge everyone to look out for postpartum residents, because this is real. I remember crying in the bathroom at UHC. Sorry, I'm getting emotional. At UHC after every patient, with basically being unable to perform my duties and texting Erica and saying that I need help. If Erica wouldn't have identified that I needed help, I don't necessarily know where I would have ended up. So I'm very grateful to her for that. Anyways, this is a satire piece from Kevin MD. Basically, you know, so we have all these things that we go through, but how should we deal with it? Basically, suck it up, buttercup, you're lucky to be here. That's kind of what's portrayed as as how we should handle it. So again, this is satire, but never touch your phone. Male doctors who touch their phones are using them as information gathering devices, not you. Girl doctors are texting their boyfriends. Worse, they're texting their babysitters. I remember getting an evaluation from UHC during a month when Luca, my oldest son, was having a lot of trouble at daycare, was biting. Daycare was calling me literally every 2 hours about him. And I remember getting an evaluation that said I was distracted because I was on my phone all the time. I wasn't Facebooking. I was checking on my children. Maternity leave places an unfair burden on all those around you. Think of the patients. After all, just have the baby during your lunch break. Never cry. Never look like you're about to cry. Never look like you just cried. But never appear cold or emotionless. There's only one emotion for you, and that's gratitude. Speaking of crying, what are the perceptions on crying? There's only one article out there about this. This was Teaching and Learning in Medicine in 2009. The purpose was to understand basically experiences and attitudes related to crying among third-year medical students and interns in 301. So 69% of students and 74% of interns reported crying for reasons related to medicine during the past year. Women cried more often than men due to stress, and 67% found it unprofessional to cry out of stress in front of colleagues. I'm not sure why that is. I mean, I'm sure it's dogma that, crying makes you look weak. But I would argue sometimes it's a good stress relief and coping mechanism. So, how do we be both? How do we balance our mental health to be both the ideal worker and the perfect mom? This is from the Harvard Business Review. The tension and guilt I feel as a working mother isn't something I can relieve on my own or even with support from my family, focused husband, fabulous nanny, dear circle of sister moms, and deeply empathetic boss and colleagues. It will take an entire society to truly ease the burden. While I and most other working moms I know would love to give 100% to both our jobs and kids, we can't accomplish the impossible. My challenge to this is, why do we have to be both? Why do we have to be both an ideal worker and a perfect mom? To me, being 100% in either of those is not attainable, feasible, or actually desirable. Why is it that the ideal worker can't include any momness? Why must the ideal worker act like she doesn't have children, doesn't have family issues to deal with while she's at work? And why does the mom have to act like she doesn't have work issues? Why does she have to completely be 100% in mom mode all the time when she's not at work? I don't see a reason. All right, on to microaggressions. So microaggressions are a comment or action that subtly and often unconsciously or unintentionally expresses a prejudiced attitude towards a member of a marginalized group. So I don't know if any of you guys are on Med Twitter. It's one of my favorite platforms. There is a surgery resident from Michigan who runs an account called OR Barbie. She recently deactivated for some other issues, but there was a big microaggression towards her username. So somebody commented that she couldn't be professional because her Twitter handle, or the username at the top, had Barbie in it. And because Barbie was female, blonde, and attractive, that wasn't a good role model for a surgeon. So there was a big movement across men and women of the medical Twitter community to change their handles or their usernames to include Barbie in them, to show that Barbie can be professional, and professionalism doesn't have a gender or a specific look. So a couple quotes. He said, "Look, even women can be part of the problem." It was actually a woman who commented on her Barbie reference. "I'm not changing who I am to make misogynistic men more comfortable. And for the record, Barbie was a bad B word who was educated and career focused. Women are not less credible because we look a certain way. Let's shift to talking about systems and biases, not how women can fit an age restrictive narrative. P.S. Gender neutral challenge to embrace your inner Barbie today." A couple other memes of microaggressions here. This has happened to me so many times. "I'll be performing whatever procedure today. Do you have any questions? Yeah, can I talk to the doctor?" It happens in other fields too, other male-dominated fields. "Overheard in the airport. Why is that stewardess dressed in a pilot outfit? I don't know, maybe she's a pilot." Last week I heard my father utter the words, "a woman doctor." Apparently he's not aware that now they're just called doctors. There was another microaggression in the med Twitter community where this conservative journalist tweeted, I'm going to get harassed for saying this, but every woman should know how to cook and bake for her loved ones. It's part of being an incredible nurturer and caregiver. There was a huge response to this. So every woman should be able to do a spinal tap on a 4-day-old baby and realign a dislocated shoulder. It's part of being an incredible nurturer and caregiver. Every woman should know how to crack the chest and place a cordis on her patient. It's part of being an incredible nurturer and a caregiver. Every woman should know how to do a crike, or at least jet ventilate. It's part of being an incredible nurturer and caregiver. So, exploring gender biases in nursing evaluations of emergency medicine. I found this article super interesting. So it was from Academic Emergency Medicine in November of 2019. It was a single site Indiana University EM program. So they compared 1,000 nursing evaluations of male and female residents to their IT scores and their milestone evaluations. So female residents compared to their male counterparts were reported to be less professional in their interactions with nurses, have less effective team leadership skills, and nurses said they would be less comfortable with females taking care of their family members. 51% of female residents had negative ability comments compared to 20% of males. Surveys were completed anonymously, so they couldn't track what gender of nurse completed these surveys. What do you think their milestones and ITU scores showed? Anybody have a guess? There were no significant differences in skills or abilities between male and female residents based on IT scores or milestone evaluations. Anybody have a theory on why nursing rated female residents lower than male residents when their objective measures were the same?
Many nurses are also female.
Okay. Yep, that's a good thought. And we'll talk about some gender theories coming up that might explain why they found those things.
Well, regardless of whether the person given the evaluation is male or female, they're all stuck with the historical scheme of what a strong doctor is and how they portray themselves and conduct themselves and everything else. So it's, you know, whether it's a male or a female nurse responding, their whole expectation of what a better doctor is skewed from the get-go.
Right. This study was from the Journal of Graduate Medical Education in 2018. It was gender bias in simulation-based assessments of emergency medicine residents. So this was a retrospective cohort study of residents at a single urban residency program. They hypothesized that they could look at simulation of male versus female residents, and that would be more objective than on-shift attending or nursing evaluations. And that hopefully would take away some of the interprofessional strife that that the different residents may encounter. They scored each resident on 12 simulation cases and mapped milestone language to critical actions, kind of like oral board style, but simulation. 48 faculty raters, 25% of men, and 100 residents. They found no effect of resident gender or resident on gender scores. Female raters tended to rate residents higher, regardless of gender, 2.9% higher than their male colleagues rating other residents. So female raters tended to be more positive. This study was from JAMA in 2017. Comparison of male versus female resident milestone evaluations by faculty during training. So this was across 8 EM training programs, retrospective, longitudinal, 33,000 evaluations of EM residents by 285 faculty members, which were pretty decently evenly distributed for emergency medicine. So 68% male attendings and 66% male residents. They found that PGY1 score distribution was similar for males and females, but once residents got to senior level of PGY3, males were evaluated at a higher milestone more frequently. Does anybody have any theories on why this is? Okay, we'll talk about it in a second. PGY1 females received higher scores in multitasking, diagnosis, and accountability. But when they got to third year, the men were rated higher in all subcompetencies. But no difference in ratings between male versus female faculty members. So there's a theory called role incongruity. So basically it says if somebody acts different from a role that is a stereotype or expected, they're going to be less well perceived. So third-year residents, the stereotype is they need to be assertive, they need to be independent, confident, which in medicine stereotypically is seen as a stereotypical male energy. So the thought is that female residents who act in this manner, assertive, confident, etc., are going to be negatively perceived, accounting for their worse ratings by either faculty or nursing. So this was from Academic Medicine in November of 2019, the effect of professional background and gender on residents' perception of leadership. So it was built on prior work in leadership categorization theory, which basically says that there are cognitive categories known as protypes, meaning certain people share similar characteristics as the norm. And if someone differs from the norm, it causes upset in the communication style. So as Dr. Lander had alluded to before, the prototype of a team leader in medicine historically is assertive, male, confident, loud, where non-leaders can be perceived, the prototype of non-leaders is perceived as quiet, passive, maybe not a physician, female, not as assertive. So this study hypothesized that residents would rate physicians as better leaders than nurse practitioners and rate males as better leaders than females. So they had 4 people complete a standardized scripted sim scenario. So they literally said the exact same thing. They were all dressed in white coats. They were obviously identified as the gender that they are. So they were obviously able to be identified as male or female. They introduced themselves at the beginning of the video. They said, "Hi, I'm Dr. Angeline. I'll be your physician today. I'll be your doctor." Or, "Hi, I'm so-and-so. I'll be your NP today." They led an 8-person team under direction from themselves. And the scenarios reviewed and rated by 160 residents in California from anesthesia, EM, OBGYN, and surgery programs. They looked at overall performance, leadership, problem solving, situational awareness, resource utilization, and communication. No significant effect of team leader background on performance ratings. So it didn't matter NP or MD, they rated them basically the same. But residents rated female team leaders lower in leadership skills and communication skills. Again, in a scripted scenario where everybody did the same thing. There was no difference between genders in overall performance, problem solving, situational awareness, and resource utilization. So I think that goes back to the prototype theory as well as the role incongruity, because in the media, in movies, in TV shows, in the history of medicine, leaders exhibit a stereotypical male persona. So even though these female providers said the exact same thing, they were thought to be less than just because of their delivery, basically. They associated descriptors with positive leadership skills as firm, decisive, and direct, and encourages input and listens to staff feedback. There's also something called the backlash effect. It's a phenomenon in which women who display traits counter to the female stereotype, similar to role incongruity, are at increased risk of prejudice and discrimination. All right, this study was from Patient Education and Counseling, 2018, and it was how female and male physicians' communication is perceived differently. So this author found that females show more patient-centered communication with partnership building and empathy, And patients were more satisfied when female physicians sat closer, spent less time reading the medical record, had a softer voice, self-touch, an exam room that appeared very medical. So they liked their female doctors. They were more satisfied with their female doctors if they acted more stereotypically female. Patients were more satisfied with males when they sat farther away, spent more time reading the medical record, used a louder voice, less self-touch, and more relaxed exam rooms. Again, here's the role congruity theory. So when women acted how patients expected a woman should act, they were happy. All right, to summarize, family planning, career planning can coexist without having to sacrifice one for the other. Female trainees are at increased risk for burnout and postpartum depression, and we're really good at hiding it. There are a lot of social undertones female residents must navigate in regards to interprofessional communication. And anything we can do as senior residents or staff, male or female, to help support the development of communication styles of female residents, I think would be helpful and greatly appreciated. It's time for medical schools, graduate medical education, residency leadership, and media to showcase a variety of leadership styles and to try and change the norm so that if a woman is soft-spoken or if she is less assertive, it's not going to negatively affect patient care because of interprofessional issues. Here are some of my references. Here's my fam. So I really like this quote from Dr. Blackstock. She's a professor of emergency medicine at NYU. I think a lot about trying to be a role model for my children. If I'm going to be away from them, at least I'm doing good work. Thank you, guys. Does anybody have any questions or comments?
I have a question.
Yeah.
And to those that I haven't met, I'm Daniel, third-year medical student on my rotation. Do you think that the way to make the most change for kind of the systemic bias against women in medicine is better at one's own institution, or is it kind of broad medicine or the overall medical institution? Like you mentioned how there's kind of, versus other countries, less maternity leave. It's basically at the discretion of your institution. Is it better to work directly with them or try and make more institutions aware?
In my personal opinion, I think you have to start small because it's such a giant issue. I mean, so you have two components of it. You have, graduate medical education component, and then you have the U.S. in and of itself. The maternity leave in the country in and of itself is awful. So kind of reaching to start small within an institution to try and change the culture of an institution, I think would be most beneficial to start with. I don't know if you know, but we're trying to, our department personally passed a policy to allow first and third trimester residents to opt out of night shift, because there's been data that's shown that it has negative effects on the health of baby, leading to increased miscarriages, increased preterm labor, and things like that. So a lot of departments, Indiana, some people in California and in Canada, their emergency medicine departments have made this policy, and they're trying to enforce it basically institution-wide. So I think once more institutions start to do that, hopefully like national bodies like ABEM and things would get involved to kind of bring more awareness to it.
I think I speak for everyone when I say this was a really, really amazing talk. I think that I've watched sort of from afar with utmost respect for how you've gone through residency and become an amazing doctor while also being a great wife and mother. And I know it hasn't been easy. Married, obviously, to a female physician and see it at home as well, but just want to make sure that everybody gets an opportunity as well to ask questions or make comments before we move on.
That's
Brandon put a question in the chat. He was wondering if you found any studies that looked at resident performance of those who had been pregnant during residency, and looking for, like, you know, does it show that it does not affect overall performance or board certification? I can't speak. It's
I did not see anything specifically on that. Most of the data that I saw was on basically like health determinants, risk of preterm labor, things like that, but nobody's actually looked at the performance of pregnant residents. There's also not a lot of data on sorry, I'm blanking. Not a lot of data on postpartum depression in pregnant residents, really in residents at all. So that was a big data gap that I saw as well.
I think Michelle highlighted that there's not a lot of studies on this outside of the surgery world. So certainly the field of scholarship on this particular topic is wide open for anyone who is interested. And you don't have to be female. I think Michelle would agree with me when I state this, that just because there's a lecture or the concept that females face different challenges than males, it doesn't mean that males don't face their own challenges. Everyone has their own challenges, but there are definitely some that are more unique and specific to females. But I thought that was a great talk, Michelle. I'm obviously a little biased because I'm really empathetic to this topic myself, but I think it's great to bring those points to our attention and help us to be more cognizant of our colleagues who are trying to balance it all, right? And as a working mom, I have definitely felt the need to try to make things at home perfect and try to make things at work perfect. And what I have learned over the years is I've not been able to get more perfect at all. I've become less perfect, and I'm okay with that. Like, you can't have this perfect work-life balance. I think I heard one time it's more like a juggling act, and I think for me that's completely true. What is most important on one day of my life may be something related to work and something that has to be done that day, and what is most important to me on a different day or takes priority is something that has to be done for my family, and I think that's okay. And regardless if it's a family versus work balance, or a you personal priority of going out and doing something that you want versus work balance, I think this whole concept of being able to balance it all, and as the article that Michelle cited said, you know, why does it have to be perfect employee versus perfect mom? I think if we're being real with ourselves, we have to try to do the best at both things and balance them as much as we can, but don't set your standards too high, because I think everyone in this position does a really good job trying to balance life and work. And I think sometimes our own internal standards cause us to be way more critical of ourselves than anyone else would be of us. So thanks for your perspective, Michelle.
Any other questions or comments?
I think Rosanna brings up a really good point in the chat, and I'd be interested to hear if there's any thoughts from new dads in our group. As I see Garrick holding to work this morning, I think these challenges are really real for new dads too, right? Like, there's not maternity leave that is paid or supplemented in any standard way, and certainly I think that falls true for dads, but new dads face a lot of the same challenges. Maybe you're not the one actually breastfeeding while you're trying to work, but that doesn't mean that your challenges as a new dad and supporting your wife and mother who are going through all of this at home are no less. So I'd be interested to hear, not to put anyone on the spot, but dads in the group. Dan's a dad, Andrew's a dad, Garrick's a dad. Forgive me if I'm leaving out dads. I'm like scanning through all of my little gallery photos here, but any new dads during residency have any thoughts or comments to add to the perceived challenges? Because I think we need to be supportive of them too, right? Little sleep, emotional moms sometimes, crying babies when you're trying to get things done for work. You guys face challenges too.
I mean, yeah, it adds another huge responsibility. It changes your priorities. I'm not getting as good sleep as I used to. Even if I'm not breastfeeding, I wake up at night take different shifts to try and give June more sleep. I'm behind on things that I wouldn't be behind on if I didn't have a kid, because my kid's more important. It's just, but.
Thanks for that perspective.